Meeting is now.
Doctors, we are live, doctor. Sorry.
Okay.
Sorry for the mistakes.
Are we?
Yeah.
We are live, doctor.
Oh, good evening, friends. Sorry for the late. On behalf of Tamil Nadu Ophthalmic Association and myself, I extend a warm welcome to all our, especially the guest speaker of the today webinar, Dr. Sobha Sivaprasad, and the convener of the session, Dr. Kim and Anand Rajendran, panelist Dr. Vignesh, Sayed, and Mona, and other people that, and also the Tamil Nadu, our Sriram Gopal, and also the Tamil Nadu Ophthalmic Association Secretary Sriram Gopal, and Treasurer Balaji, and of course our Jayant, and editor of the journal, and Dr. Manoj, and Atik, ARC Chairman, Sharmila, and all other Ravi Kumar, and all other members of managing committee, and extend a warm welcome to all of you for this today's webinar. And especially I have to thank Dr. Sobha for readily accepting our request to give this talk on CSR. Of course, most of people, especially retinal people, will think that CSR is a very simple topic. But for general ophthalmologists and also for others, it's definitely still because one of the important day-to-day problem, CSR. For us, it may be very simple, but for patients, if you are a patient, then you will realize how serious, as a topic earlier we gave, serious retinopathy, it's serious because so much of visual disturbance and other things, they will not be able to carry out their own day-to-day activities. Still, I remember when I was a resident about more than 35 years back, patient came with a blurring of vision. And vision was 6.9, and with the 0.75 spherical, he improved to 6.6. So then he gave a glass. And next day, after 2 days, he came with the same complaint. I told Parvila and LRQ, your vision is all right. No, that I am not able to face clearly. This was discovered. Then immediately he went to our senior, Dr. PN. At that time, only I came to know this was in 1983 when I was doing a diploma. So at that time, I realized that, oh, this is a serious condition. And you have to see the ring reflex and other things. So till some of the residents, they'll do the same mistake. We are seeing so many times in the outpatient. So such an important thing. And also at that time, when we were doing so much of investigations like man to rural tuberculosis and also motion overseas and so many things. But now it is completely changed. The pathogenesis, the management, and everything has changed in this CSR. And also, I'm very happy that today our speaker, Dr. Sobha, is going to give you an elaborate presentation about CSR. Definitely, this will be useful to all of us, especially non-retina people, how to diagnose and what treatment we have to give. Definitely, it's a day-to-day, every day we are seeing 1 or 2 cases of CSR in our practice. So I'm very happy, and also extend a warm welcome to all of you. And I really thank once again, and I will give the mic to my dear brother, Dr. Kim, to introduce Dr. Sobha, and also later to Anand. I hope we will have a very useful and fruitful discussion following. Thank you once again.
Thank you, sir. And at the outset, I want to thank you as the president of TNOA and all the EC members for giving us this opportunity to the retina team to share on a very, very important topic. CSR, though simple, it plays a major role. But before that, I want to thank Dr. Sobha, who's a senior consultant at Moorfields. Everybody in India knows Dr. Sobha. She's not a new face to us. She's an Indian, of course. And the tremendous work that she has done for us, especially in creating this ornate India and then bringing a multitude of sites to do studies together has not been done in the past. And we thought it will not be possible, but she made it possible. And we have multiple papers that have been published across India it's not a single site, but multi-site data that has come. This is very important. And she has opened the path for us to follow. Thank you, Dr. Sobha. And thank you again for agreeing to give this talk on such a short notice on a very important topic. I know for many of you who do not know Dr. Sobha, she is a clinician partly, but a very big researcher. Any leading retina research that's happening in the international level, she'll be a part of that particular study. So, Dr. Sobha, I don't want to waste the time since we also started a little late.
Yeah.
I would ask Dr. Anand to give a little brief and then over to you for the rest of the talk. Anand?
Thank you, sir. Thank you. And thank you, Dr. Sobha. Like Dr. Ramakrishnan and Dr. Kim said, you really need no introduction to our fraternity. It's wonderful that you accepted to give this talk on a topic that I think is very relevant at any point. So Dr. R.K. mentioned about earlier in 80s, but I think it's very relevant. And the beauty of this particular pathology is it presents in so many different forms and so many diseases present somewhat similarly. So it's something that's very critical and very important, not just postgraduates, but also practitioners to understand about that. So with no further ado, going straight, cutting to the chase, I would invite you to kind of give your talk straight away. Thank you.
Thank you very much, Dr. Ramakrishnan, and then Dr. Kim and Dr. Anand. I'm deeply privileged to attend this meeting today and give whatever my thoughts are, and happy for a discussion as well on this important topic. I'll just go and share my screen now.
We can see your screen, Dr. Sobha.
Yeah, I'm trying to full screen. Yeah, okay.
Yes.
That's fine. Yeah, okay. So, you can see my topic, it's abbreviated into CSCR, and I just want to stress why that is the case first. So these are my disclosures. As Dr. Kim says, I work with several clinical trials and therefore have to work with several companies. So as you all know, and as Dr. Ramakrishnan just mentioned, it is a very difficult disease. We still know that the condition, we do not understand the condition well, the mechanisms are not clear. And of course, because of that, it is challenging to diagnose it and provide a treatment. So historically, this is 1866, when von Graffe described it as a syphilitic retinitis. And from then on, it has gone on to 1940, when Duke Elder decided it is central serous chorioretinopathy. So he did mention that there was a choroid may be involved. After that, things changed again, and there is a lot of discussion now on autonomic nervous system. And I think I should be proud that there's a doctor called Manish Jain, who seems to be leading in this field of autonomic nervous system, and an Indian, so we should be proud of him. Anyway, from there, it went to we thinking that it is a retinal pigment epithelial change, a leak at that level. In 1967, our gas came up saying, actually, it is not. It is a hydrostatic pressure that is increased in the choroid, and therefore you have choriocapillary increased permeability. Very recently, Spade has come up with a new theory saying it is actually due to vortex vein overload. Maybe it's a scleral rigidity that is causing it. So as you can see, we have been changing our thought process on this condition for a very, very long time. And I'm not sure we are actually, I can confirm that we know about it, much more about it than we did in 1866. So that's how difficult this disease is. So the current definition, as I said earlier, is central serous chorioretinopathy. We used to call it CSR because we thought it's central serous retinopathy due to retinal pigment epithelial changes that we could see on our ophthalmoscopy, etc. But now with the availability of OCT, we know that it is central serous chorioretinopathy because we see leakage from the choroid and there is a defect in the retinal pigment epithelium. To take things further, this is a schematic representation of the choroid. The larger vessels are the ones in red which leak due to hyperpermeability, and that causes the choriocapillaries that sit just under the Bruch's membrane to compress and also injure the RPE because it is stretched, pulled, and also a defect occurs or multiple defect occurs. And then those changes then causes subretinal fluid, which we see on OCT, and then intraretinal changes. So that's the course of action as we know today. When you ask me what's the classification of central serous chorioretinopathy, you will know that it has been evolving for many, many years, but I would still stick on to, for clinical decisions, I still stick on to just two, acute CSR and chronic CSR. Of course, in chronic CSR, we can further divide it as whether there is a choroidal neovascular membrane complicating it or whether there are cystoid retinal degeneration that is complicating it. These are poor prognosis, but at least we will try and keep it simple. I will cover the more complex cases, but complex classifications. But so far, I think I still like to stick to my old thought process of acute and chronic CSR. And this is based on symptoms, the duration of symptoms. We have put a classification as anything older than 4 months duration, we call it chronic, although we don't know where and who derived this 4 months from, but that's what we use in clinic. And extent of leakage of angiography is another reason why you call it acute and chronic. Acute is usually due to 1 or 2 max of dot or blot leaks, while chronic CSR will have multiple window defects and RPE changes. This is a typical example of an acute CSR. It's sometimes associated with a pigment epithelial detachment. It may be within the CSR or just outside. And then you have this pocket of subretinal fluid, very well defined on infrared reflectance, and on autofluorescence, you don't see any hyper autofluorescence of it. So that clearly we believe is an acute CSR. And the fluorescence will show 1 or 2 leaks. And on ICG, in this case, this is a late frame, but you may be able to see 1 or 2 dilated choroidal vessel. On color photographs, you see a serous detachment at the macula usually. This is the typical teaching that we have, that if you see an acute CSR, the fluorescent angiography is smokestack appearance, as you can see here. But this is very rarely seen in clinic, actually. This is the teaching that we have always been informed, but I think this is the more usual one. This is a blot, ink blot appearance of leakage. Here, I want to stress that with the availability of OCT, it is not only the leakage that on fluorescein that matters. You can see here that the subretinal fluid, if you look at the photoreceptors just on top of it, it is all very blunted and lost. Now, if this patient sees a subretinal fluid disappears, this patient will still have poor vision compared to the previous picture where the photoreceptors were very healthy still. So this is a further sign of how you should proceed when you inform the prognosis to a patient. If I see a patient with blunted photoreceptors, I will always say your vision will remain poor and never as perfect as what you had before. This is chronic central serous chorioretinopathy. Here you can, as I said earlier, loads of window defect due to previous RPE changes, and also there will be acute on chronic changes where you see leaks on fluorescent angiography. These are the most difficult cases that we have, and it's very difficult to treat. Here you can see another case of chronic CSCR. At this point, I will stress that the lesion is more in the peripapillary area, but you see the track signs of fluid on autofluorescence, well seen on autofluorescence. Now, this is also chronic CSR, but this time it's arising mainly from the peripapillary area. Of all the CSRs we classify by location, it is the peripapillary CSRs that carry the worst prognosis. This is the secondary change that can occur in chronic central serous chorioretinopathy, and that is large cystoid spaces or skytic cavities. And you can see on autofluorescence that the whole area of plaque of RPE changes. Again, this patient's CSR is abutting from the optic nerve, peripapillary edge, and these are extremely difficult. This, in my eyes, this is already a gone case. I wouldn't spend a lot of treatment on him because it's very unlikely to improve. This is yet another case, again in lots of schisis, tracts, RPE changes, another example of chronic CSR. I just want to stress again the importance of looking at peripapillary distribution of CSR. I would always warn the patients this is a disease that we really don't know which way it will progress, and most probably you'll end up with poor vision. So CSR has now been redefined by some people with the availability of OCT into being within the pachychoroid spectrum. Pachychoroid just means that they are dilated large choroidal vessels, and this then compresses the choriocapillaries, which is shown in black dash, and then on top of that, it will compress the RPE. So this is pachychoroid. The problem with the spectrum is that we just don't know what is the thickness, normal thickness of a choroid, and whether a 500 in one person, a 500 microns thickness in one person is normal for another. So there is a lot of individual variation in choroidal thickness. But for a clinical purpose, if you have a thick choroid, like you see in the first case, a diffuse thick choroid in the upper OCT, that's a typical example where you have a subretinal fluid there and a PCN or a neovasculopathy as well. In the second one, you can see that actually the pachy vessel is very restricted to one small area, a localized pachychoroid, but even that can cause CSR. So many people have tried to calculate choroidal vascular index, etc., to measure choroidal thickness, choroidal stroma. I don't believe that that is often accurate. First of all, because CSR can occur in a single or multiple pachy vessel causing trouble. It doesn't necessarily need to be the whole choroid that is at fault. So this is an example of the pachychoroid clinical spectrum. Usually in eyes with CSR, if you look at the other eye, there will be pigmentary changes with thick choroid, and they are pachychoroid pigment epitheliopathy. With the emergence of subretinal fluid in those eyes, you get central serous chorioretinopathy. And then if you follow up these patients longer, some of them develop pachychoroid neovasculopathy. Very rarely, these eyes also progress to polypoidal choroidal vasculopathy or PCV. Now, there's a big question on, does all PCV actually start off with CSR? And the answer is no. You can get polypoidal choroidal vasculopathy without any CSR before that as a single entity. This is just a spectrum. They don't need to be followed in order. And nowadays, there is more classification on what constitutes pachychoroid clinical spectrum. As I said, they have now added this peripapillary pachychoroid spectrum into this group as well, and also for focal choroidal excavation. So a few sentences about the choroid, a very unknown territory, and really that's where the work on CSR should be focused on. You see in the picture A, you see this large pool of choroidal vessel just leaking, and these are probably the reason why this patient got CSR. And then, as I said earlier, there's the B, there's a focal pachy vessel there, the rest of the choroid looks okay. And C, another example where you get a PED over that. And another example of a very thick choroid. But I want to stress here, this is the article by Professor Francois Beher-Cohen, which shows that this hyper-reflective foci that you see in the choroid may be of significance. She's doubting that there is an inflammatory pathology to CSR. None of the articles have ever proven that, but it's worth investigating. Another issue I want to show in G, like the figure G, is the blunted photoreceptors. Now, this case is an extremely bad case and is unlikely to have any visual improvement. This is the new theory that Rick Spade brought up about, I think it's last year, when he thought it is the venous overload that these eyes have. So if the 4 vortex vein, if any 2 or more vortex vein gets compressed, either due to thick sclera or due to whatever pathology, the vortex vein is the drainage system, and that is why an obstruction of the vortex vein can cause an overload in the choroidal circulation, and that is why the choroid is thickened and we get CSR. That is one of his, that is his most recent theory. And you can see in the lower frame the anastomosis between the superior and inferior vortex vein. It is just to show how the choroidal vessels try to compensate to the drainage system so that all 4 quadrants get sufficient blood supply, get sufficient drainage despite obstruction to 1 or 2 of them. This is yet to be proven, but this is the latest. So coming to the diagnostic criteria in clinic, what do we go by? We look for presence of subretinal fluid and at least one area of RPE alterations. And by diagnosis, how do you diagnose it? Of course, you can use OCT to look at a thick choroid associated with it. And this group diagnosed subfoveal choroidal thickness of 400 microns or more as a diagnostic criteria for CSR. Of course, you can do fluorescent angiography and isolate the leaks, or look for hyperpermeability on ICG. So this is the diagnostic criteria of CSC today. I brought this up because very recently Chablani and group have come up with a more sophisticated classification of CSR. They've divided into simple, complex, and atypical. And if you look at it, it's actually acute and chronic and atypical, but I will cover this in the way they have classified. So the simple, if you think of it in your clinic, these are the acute ones that may present itself as first episode, then it's primary. It may appear and reappear, then it's recurrent, or it can completely resolve. And in that case, it's resolved. Some of these do remain persistent beyond the 4 months that we have got cut off for. In this classification system, they've said SRF of more than 6 months duration. Then you could call them simple persistent CSCR. And if I showed examples of a blunted photoreceptors, if it's associated with that, then you add plus or minus outer retinal atrophy. So the top bit is all about acute CSC and its course of action. The second bit is the complex one, which I also showed as examples of chronic CSC. In this case, it's defined as total area of RPA alterations of more than 2 disc areas. Again, you can have primary, recurrent, and resolved. Same definition, persistent if more than 6 months, and with outer retinal atrophy or intraretinal fluid. So I think you get the gist of it. It is because it's very complicated, that is why I said I'd rather go back to my acute and chronic and manage our patients like that. But I'm sure this will evolve further, and probably this may be the classification we will use in future. I also want to highlight the third group, which is atypical CSCR, and I'll cover some of them as I go along. So these are examples of atypical CSR. So this is multifocal CSR. You see it in, usually you see it in renal patients, transplant patients, etc. They seem to have multiple RPE breaks all over, and they may also have a thick choroid, but some may have very focal pachyvessels causing the problem. They may be associated with fibrin as well. This is another example, this time mainly fibrinous CSR, usually seen in pregnancy, etc. You see this type of appearance. Do not forget, it doesn't look typical, but if you have seen some of these pictures, then you will remember that just because you have fibrin, it does not mean it is not CSR. You have to look again, look at the OCT and the color photographs together. The third one here that is just steroid-induced CSR. I brought this up just to show you that just because a patient is on steroid Only the history will tell us the patient is on steroid. The clinical picture will not give us any clue of whether the patient is on steroid or not. So you do need to ask the history of steroid use. This is a rare example of a detachment, bullous CSR seen in the periphery. Again, if you see this sort of appearance once, you probably will remember in all exudative RD, always think of CSR. This is an example of that can be mixed up with subretinal hemorrhage due to age-related macular degeneration. This is actually a RIP due to CSR that still presents with a very similar appearance to hemorrhage following AMD. So just look out for examine the other eye, make sure that this is CSR and not AMD. The other eye will give the clue of drusen, RPE changes, etc. of AMD if you are to look at it. But I think the main reason how you can diagnose it is using OCT. You will definitely see the RIP in these cases. This is the example of a choroidal neovascularization, or nowadays called macular neovascularization, that complicates CSR, but it also can complicate AMD, as you know, wet AMDs. So this is another reason why you should be doing OCT and examining the other eye so that you rule out wet AMD. Fortunately, whether it's due to CSR or due to wet AMD, the treatment is anti-VEGF therapy. So these eyes respond really well to anti-VEGF therapy. I think Dr. Kim mentioned and Dr. Ramakrishnan mentioned about the other causes of SRF. I think that's very important for us these days with all the multimodal imaging we have, that we try and make sure that CSR is just idiopathic retinal, idiopathic chronic central serous chorioretinopathy rather than due to any other causes. This is where it becomes very challenging, and sometimes in clinic it is we become very unsure, but history will give us a lot about drug toxicity, especially nowadays with patients on Merck inhibitors for cancer therapy. We do see a lot of cases with subretinal fluid. You really need to ask the history on whether the patients are on any such medications. So this is dome maculopathy, first diagnosed by Alan Godric and group in France. You can see that they always have a pocket of subretinal fluid with a dome. So the dome is best seen both on vertical scans as well as horizontal. Make sure you get this diagnosis right, because whatever you treat these patients with, that subretinal fluid will not go away. It goes away on its own and it comes back on its own. There's no way any of our current treatment will help a dome-shaped macula. So we don't do anything for this condition. This is an optic disc pit with subretinal fluid. Again, examining the disc is very important in CSR. You can rule out whether it's a pachychoroid spectrum causing CSR or an optic disc anomaly causing the fluid to accumulate. This is the OCT appearance of the pit causing the fluid accumulation in the subretinal space. As I said earlier, this is another publication on focal choroidal excavation. It just shows that the choroid gets deformed and causing the retina also to get this excavation. It all seems to be related to mainly to CSR. Lastly, and the most difficult, are patients with vitelliform with subretinal fluid accumulation. It's a pretty tricky situation, especially in an older individual. We really have to do an autofluorescence for these patients to first diagnose vitelliform, and then you can be quite sure if there is vitelliform changes with subretinal fluid and it's of an older age group and it's bilateral. Most of the time we can diagnose the case of vitelliform, but it's not easy. So in the next few slides, I'll go through the management. Again, the management is based on your classification. I'm going back to saying, how do you manage an acute CSR, whether it be primary, recurrent, or with and without outer segment disruption. In all cases of acute CSR, our treatment here, at least in the UK, is to just sit and wait on it for at least 6 months. because it's a self-limiting disorder. We try to see them every 4 to 6 months, but we try and treat the primary anomaly, and that is only to tell them to stop steroids. Improve their sleep, because sleep apnea is a very common predisposing factor of CSR, and of course to decrease stress level. We just don't know why stress is related to CSR. It may be due to hypercortisolism, but only some people are prone to it. It's also surprising that patients who are on Osidex rarely develop CSR within the eye, and it is exogenous exogenous steroid intake, usually skin cream or nasal spray, etc., or oral steroids that cause CSR. So just ask the history and ask them to stop those medications if possible. Visual acuity usually improves in most cases, but as Dr. Ramakrishnan says, it will never be perfect. They will always complain of color vision abnormalities or lack of contrast. And they see their television, their color is not as normal as before, etc. This is self-limiting. When do we treat them? Acute CSR. We rarely treat, as I said, but we may have to in cases of a patient's only eye being affected and his quality of life has completely gone down, becomes loss of his independence has gone, and we really need to treat him. We have treated, for example, pilots who definitely need both their eyes and will not be allowed to work without it. Very rarely such cases will be treated. And otherwise, as a teaching, if you want to take this away, acute CSR, don't treat. So why do you treat chronic CSR? Now, these are the ones that we want a complete resolution of their subretinal fluid so that they do not cause damage to the photoreceptors. We want their visual function to improve, and we believe that by doing a treatment, we may be able to prevent its recurrence, although we are still unsure about whether we can prevent recurrences or prevent progression. The problem with CSR compared to all other disease areas we have in retina is that it is very difficult to do a randomized control trial on them, because the spontaneous resolution is very high, whether the patient has acute or chronic CSR. And that is why we do not take into account any prospective observational studies on a sample size, because we really won't know whether the drug is working or it is spontaneous resolution. And CSR is a very heterogeneous condition. If we do not do the trial properly, we'll end up having a lot of, for example, AA assigned patients in one arm rather than the other, etc. So you really need to work on making the trial cohort very homogeneous on both sides. That's why we usually take patients who have at least 4 to 6 months of persistent subfoveal subretinal fluid before for trials. Examples of heterogeneity in chronic CSR, as I said earlier, AA sign is a sign of a choroidal neovascularization, best seen on OCTA or fluorescent angiography. We see a lot of heterogeneous substance within a AA sign, but not all of them will have a membrane. Loss of subfoveal ellipsoid zone, I've been saying that throughout the talk, that it's a poor sign, but very recently, a poor prognostic indicator of visual acuity. But very recently, Camille Boone's group, Elon, etc., have published that even with foveal PDT done on patients, they saw a reconstitution of the ellipsoid zone and the external limiting membrane and improvement of vision. But I would still say it's very stunted. A photoreceptor means their visual cycle is not working and therefore unlikely to improve. Atrophy involving the fovea is, of course, a poor prognostic indicator and should not be included in trials. And try and keep, if you're running a CSR trial, make sure that you have a control arm and make the groups as homogeneous as possible. As I said earlier, the first thing we do is to eliminate their risk factors. So you stop steroids if possible. I mean, of course, for an asthmatic, etc., you do need to talk with their general physicians before you decide to force them to stop it. Cushing's disease and syndrome, many people have got into the habit of looking at hypercortisolism over 24 hours, etc. I believe the yield is very low. Even if you do 200 patients, etc., look at your cortisol levels, you may get like one patient with an increased cortisol level and or almost none with Cushing's disease. I'm not saying you shouldn't do it, but it's a very expensive test and very inconvenient test for very little yield. Unless you have a strong doubt of it, I would defer doing hypercortisolism estimation in all CSR patients. I would definitely ask the patient to reduce their stress level, anxiety level, improve their sleep, healthy diet, less quarreling at home, less stress at work, and go for a holiday. Some of them just resolve like that. Now, coming to focal photocoagulation, this is what we have all done over the years. This was our first line of treatment, that we treat that focal leak with usually a light argon laser burn. But there's only one good randomized controlled trial on that, and it shows that it does not affect the recurrence rate or have any difference in visual acuity with ones who had laser versus those who did not. Of course, with focal laser, we must remember that laser by itself is a complication for choroidal neovascularization. And if you should do a light burn, because otherwise the scotoma itself is a complication of laser. But given that we do not have PDT these days and that patients need to be treated, we do attempt focal laser yet again. Focal laser only allows the seal to seal off the RPE changes. It does not influence the choroid as well at all, and that is why we get recurrence of CSR with laser. So there are many different ways of doing laser. For CSR and Chaplani's group have tried this Navilas laser. A lot of us do micropulse laser. And then there's a new way of high density subthreshold micropulse laser. This has been tried in the PLACE trial. This high density subthreshold micropulse was inferior to PDT in terms of resolution of subretinal fluid. Ideally, if we had all these treatments with us, we would not be using any of these laser modalities. But because we don't have them, we still revert to having these as our treatment options. So when you come to management of persistent central serous chororetinopathy, that is an acute CSR that lasts more than 6 months and patients frustrated, or in patients with chronic CSR, please explain to them that the visual acuity will remain impaired despite whatever we do. And if their vision improves, it's a bonus for them. These are type A personalities. If you don't consent them properly, they'll come back and bite you. Why did you do laser? And because of laser, my eye has now lost its vision. Or why did you do PDT on me? And that is why you have lost vision. So you have to be very, very careful in consenting this group of patients. Eliminate all risk factors. Warn them, show them their OCT and tell them that the outer retinal layer is damaged. This is the last resort that we are going to try, and then only treat them. So the treatment of choice for us is photodynamic therapy. And that's for chronic CSR. And photodynamic therapy, as you all know, we give a verteporfin intravenously, and we activate it using a laser. And this then causes the choroidal endothelial cells to become more stronger, and the damage will allow it to remodel itself and therefore reduce the thickness of the choroid and have less insult on the choriocapillaries. It does not have an effect on the retina or the retinal pigment epithelium. When do we do PDT? As I said, we do not do anything on acute CSR, but we may have to do it in very rare occasions after 6 months, or in very acute cases, as I said, due to occupation or being one-eyed. Chronic CSR, of course, we try to do it as quickly as we can if we know a history of about 6 months of subretinal fluid. And this is, I wrote, choose your patients wisely, because they often come back and bite you. So that's the only reason why I wrote that. And then visual impairment or worsening of CSR still occurs with PDT. The other consent you have to do with PDT, when you do PDT on these patients, are in the first week of having PDT. A lot of patients complain of worsening of visual acuity, and especially when you try and do an OCT at that time, actually the choroid thickens. And this sometimes is very frightening for the treating doctor as well as for the patients. So as long as this is a warning sign for the patients, they should not run back and cause problems for us or for them. The results are usually best after 1 month when you have complete resolution of the subretinal fluid. The choroidal thickness seems to go down, although saying that many a times the choroidal thickness does not behave just as well. Then you compare it with your fellow eye, and then you have to believe that, yes, there is some thinning of the choroid. There are several ways by which you can treat with PDT. The ideal one we used to do for AMD is full dose PDT of 6 milligram per meter square verteprofen. But for CSR, we tend to do less. So you can either do half dose PDT, so you reduce it to 3 milligram per meter square, or you do from the full fluence PDT is 50 joules, you reduce it to 25 joules, or you can reduce the time from 83 seconds to 42 seconds. So you can do half dose PDT, half fluence PDT, or half time PDT for CSR. Procedure, I'm sure the people who do it know it. You give the infusion for over 10 or for a period of 10 minutes, and exactly at 15 minutes you apply the laser treatment for whatever time you have primed your device for. The PLACE trial is currently the best trial we have that have compared photodynamic therapy versus micropulse laser. And you can see here that half dose PDT was superior to micropulse laser. And both for subretinal fluid resolution, increase in best corrected visual acuity, and even microperimetry changes. So definitely half dose PDT is superior to laser, and we would have used it if we had it. We don't have it at present. SPECTRA trial is another trial that looked at half dose PDT versus eplerenone. Again, half dose PDT was superior to eplerenone therapy. There are poor treatment outcomes with PDT. We should know that we should avoid doing PDT in patients with cystoid changes in the retina, because they rarely have any use with PDT, and also the patients with atrophy in the center. Poor baseline visual acuity, as I showed earlier, disruption of the ellipsoid zone. That is a question mark because of this recent paper, but we will not attempt it if the ellipsoid layer looks pretty poor. Diffuse hyperfluorescent pattern on ICG. Many people do PDT based on ICG. We still tend to do it based on fluorescent angiography. But if it's diffuse, you don't know where to apply it, and that is why they try to avoid it. And you have large PEDs, you will try to avoid it as well. Safety, it's a very safe procedure. Of course, if you have extravasation of verteprofen, you may cause the sight problems, but otherwise, very, very, very safe therapy. The only fear we all have about PDT is whether it will cause a choroidal infarct, but there is very little literature on that, and very few people in our experience actually develop a choroidal infarct. And even if they do show a sudden decline of vision, maybe due to the immediate infarction, it tends to come back. Contraindications of PDT, we do not do it in pregnancy or patients with liver disease, and especially porphyria. I'll just go through a few cases for those who are interested in PDT. So the treatment spot size is, unlike AMD, we restrict it to the area of leakage only on fluorescent angiography, and to the area of choroidal leakage if you're doing ICGA. So this is one lady, you know, it's a male's disease, but you can get it in females, especially postmenopausal. So this is a 53-year-old lady with right central serous chorioretinopathy with visual acuity of 624 improving to 69. And here you can see the other eye looks perfect, no RPE changes even. And then you look at the right eye, you definitely see this area of leakage. And what we tend to do is we measure just that area of leakage on fluorescent angiography, and then we apply the laser at that spot only. And then you see that that fluid has resolved. What I want to point out here is that the visual acuity has improved, but you can see the outer retina has flattened out and it's caused a thin outer layer. That might have been the case if it has resolved on its own, but I want to show you that is the reason why we are very cautious when we explain the outcome to these patients, because that may in time result in poor visual acuity. This is a gentleman, 39-year-old, typical age for a central serous retinopathy. Left eye visual acuity 6.9. Again, right eye seems perfect. Left eye, you see this. Now, this is the case where you doubt several times of whether or not you will do it. There is definite subretinal fluid. It's very chronic. All the photoreceptors have, seems damaged. The hyperreflective foci, really bad case. But we attempted to laser. You only laser the area where it's leaking, which is pretty small in this case. You apply it, and then you see that the fluid has gone away. Visual acuity has improved. This is immediate, but you can see there is no photoreceptors in that layer. I would be tempted to also give this gentleman a poor prognosis, because it may be the onset of atrophy for him in that area, although the immediate result is good. This is another chap who is 40-year-old with right CSR, who was first given eplenon for 3 weeks. And this is his good eye, and this is his bad eye. And you can see that subretinal fluid, again, a very stunted outer retinal photoreceptor layer, but a very small leak. And we only treat the leak again. I just want to emphasize, even though they are thickened choriocapillary choroidal vessels on ICG, we tend to stick to only that leak. This is another example of its resolution completely, but again, the outer retina is sunk down. Fourth case, again, a lady having CSR for 2 years, visual acuity 6.9. This is the good eye, and the bad eye here, you can see 2 spots now, one in the peripapillary area and one in the macular area. Again, we measured that, do the macula first, and then once that's over, depending on your time, you then start again, do the laser in the other area, also on the same time of 42 seconds, or if you're doing 83 seconds, but not new injection. On the same verteporfin dye, do it repeatedly. I've never gone before more than 2 times, but I've heard that people have given 3, etc. Again, see, it's a typical appearance of how the outer retina behaves after PDT. It definitely resolves the fluid, but we don't know what its long-term outcome is. This is the 5th case, again, of left CSR, and here this is a normal eye. Here I want to show where the leak is. This is in the peripapillary area between the fovea and the disc. Again, we treated only that area. Although if you look at the ICG, there are other areas of hyperpermeability. We do not go around treating more than that area. And you see complete resolution. So these are just some examples to show how we perform PDT. It may be different in different areas, but this is my experience. Now, going to subthreshold laser, as we all know, we do not have photodynamic therapy at present, at least most parts of the world. So we tend to go back to doing our argon laser or micropulse or Pascal with endpoint management, or when the Reuter group does selective retinal therapy. We don't have that. And this is the endpoint management where you can adjust the dosing on the camera, on the laser machine, and then you can apply this sort of continuous waveform or pattern scanning form to that. I haven't treated it like this ever to date, but this is what is being done for this sort of laser. That is, you can treat as close to the fovea as possible, depending, that is what is being reported. This is why it's called a pan-macular laser style. I will actually be very conservative and I will not be going down that route, but have to say that it's being done. For a subthreshold laser to work, this is a group from Manchester who reported that if you have less subretinal fluid, a very narrow PED, and less hyperreflective foci, and the RPE appears intact, you can try to do subthreshold laser in these eyes. Next, when do we do intravitreal anti-VEGF treatment? We only do it when you have definitive evidence of choroidal neovascularization complicating SCSC. And then the next is eplerenone. I know some of you still like to use eplerenone despite trials showing it doesn't work. So this Vichy trial is one we did in the UK. We compared eplerenone versus placebo in chronic CSR, and chronic CSR was defined as patients who have at least 4 months duration of subretinal fluid. It was a 12-month trial, and it was a large trial done across 22 sites looking at subretinal fluid and best-corrected visual acuity in 104 participants. We did a lot of analysis on this patient, and oral eplerenone was started at low dose to allow to prevent hyperkalemia. Patients were looked after really well in this trial, but the outcome was that there was no difference between eplerenone and best corrected visual acuity. Now, some may argue, especially it's there in the case reports, etc., that if a patient had thick choroid of 500 microns or more, they respond to eplerenone. We could not analyze that because most of our patients had a choroidal thickness of less than 500 microns. So I wouldn't be able to say that, but it was a homogeneous cohort between the two arms, and there was no difference in best corrected visual acuity, no difference in low visual acuity, and no difference in quality of life of the patients, and no difference in subretinal fluid either. So in fact, the placebo group had better resolution of subretinal fluid than the intervention arm of eplerenone. So we have stopped using eplerenone altogether in the NHS. The summary of that was we changed the practice of not using eplerenone, and to advice was to use alternative interventions. So when we now go back and look at all the treatments we have for CSR, I didn't mention there are plenty of other treatments that have been tried from rifampicin onwards. If you draw a graph, safety versus effectiveness, at present PDT is the only one that is both effective and safe. Of course, you can see a lot of safe treatments on the y-axis, like aromatherapy, holidays, aspirin, eplerenone, etc. Well, none of them are effective as such. So you can't advocate those treatments. So in conclusion, we should try and do multimodal imaging so that we know what the diagnosis is, well, rule out types of CSRs that should be treated with anti-VEGF if there is macular neovascularization. We should try and reduce as many risk factors as for the patients, especially treatment of hypertension and stopping corticosteroids. And also, when we do PDT on these patients or any treatment, look at the chronicity, look at the intactness of the photoreceptor layer, and make sure patients are very aware of what you're going to do and consent them appropriately and document everything, because they are type A personality, I'm afraid. So this is the management in brief. CNV on OCTA, treat anti-VEGF. That's the only one that has got a clear outline. If you attempt to do CSR, patients without CNV or with anti-VEGF treatment, they do not respond. PDT is the best treatment if available. If not, we try subthreshold laser or our normal argon laser for lesions that are outside or extrafoveal leaks. Thank you. I think that's all I had. Yeah.
Thank you, Dr. Sobha. I think there was a wonderful talk covering the entire spectrum, starting from where it is starting to how to end that CSR. I think you beautifully covered. When we started practice, CSR was just two things. You see a CSR, it was a clinical finding, and then you either treat it with laser or you just observe.
Yeah.
So the only two things. But with advent of OCT and all the other imaging technologies, I think the whole process has changed how you see the CSR, the pathology, and then the management itself. It's no more just a single disease, but it's a entity that covers across or a spectrum of disease that it is part of.
Yeah.
I think we have a wonderful panel, young and enthusiastic panel who have a lot of experience on this. I will let Dr. Anand moderate the session on the discussions further on. And thank you, Dr. Sobha. There was really a wonderful coverage of the entire bits and pieces of CSR.
Could have done more. I don't have the energy.
Oh, no.
It's
So
a
1
really
hour.
wonderful talk. Thank you very much, Dr. Sobha. Thank you. Thanks a lot. Lot of new information.
Yeah, thank you, Dr. Sobha. Really, very comprehensive, exhaustive, and very elaborate talk. CSR is something like you mentioned, there are so many diseases that look like CSR, and, CSR looks like so many diseases. And thrown in, there are a lot of treatments also that you beautifully, elaborated. So I think you, at the very start, you kind of mentioned about this little debate with the new classification. So our initial teaching, this is basically for beginners and for postgraduates who may be tuning in. And we have here a lovely panel, as Dr. Kim said, of people from institutes as well as people from real world, from private practitioners. So it will be interesting to look at perspectives, on all these different aspects. I mean, basic clinical classification, treatment options, variations of CSR, and how one would manage challenging situations. You showed beautiful bouquet of cases. So, when you went in straight up, you talked of, acute versus chronic CSR. So I know the NHS has put its foot down and, taken the stand as 4 months. But I'd like to ask Dr. Muna Bende and then probably Sriram Gopal from the private side. When you look at the CSR walking in, and the patients, of course, because this is sometimes not a disease that that talks itself up. So with your treatment options and the fact that we are now going in, a little more aggressive with treatment options, would you still like to hold to that 3-month, classification, 3 to 4 months of acute CSCR? Then say if it's beyond that, chronic CSR, does that drive your treatment decisions? And importantly, do you rely more on imaging features like Dr. Sobha mentioned? So Dr. Muna, could you take that up, please?
Thank you, Sobha, for a wonderful overview of everything and those nice illustrative cases. Now, to put it as 3 months for an acute phase with absolutely no RP changes, then yes, I may do it. I may observe and wait. But even if it's an acute phase, if I see RP changes, then probably I'll be a little more aggressive in terms of doing a fluorescein, doing an ICG. If it's an older patient, doing an OCT angiogram. And those are cases probably I will treat more aggressively, because it's in an older patient, it's very difficult to say that the first episode is just a simple CSCR. So I would say probably it's something they never noticed, and most often they would be a chronic.
Yeah, sure, ma'am. Thank you.
I
think
totally
that's
agree
very
with ma'am. I don't think this time of 3 months is that set in stone for many reasons. One, that you can actually calculate the time only from when you've seen the patient. A lot of times you diagnose it incidentally. And I would rely more on the clinical features and the imaging findings which indicate chronicity. And a lot of times when you get an acute attack in one eye, you do see that he's had multiple attacks which he's not been aware of in the other eye. So how would you classify if, so let us say you have a 1 week history patient with a history of 1 week loss of vision in one eye. He's got chronic changes in the other eye. Would you really classify that as acute CSR? I don't think I would.
I mean, in those cases, we tend to look at the OCT, the autofluorescence, right? If you see that
Yes,
white speckled change, then it is probably chronic. I would, yeah. Any white dots, although patient symptom says, I saw it yesterday, but if you have that hyper autofluorescent dots, it is chronic. Yeah. We tend to be very conservative. Even if there are those changes, we still wait. I think it's just the way we are more conservative than any other country, I think.
Yeah, absolutely. I think there's, one needs to look at the patient as a whole. look at the other eye. I think Sriram brought that point out very well. Very often, if one eye has good vision and another eye is minimally slight loss in vision, especially in the elder age group, people may not come in early. So just moving on to imaging, you touched upon imaging. Again, we'll look at start off from very basic stuff and then move on to more advanced stuff as we scale up. So what would you think, George? And if Supriya is here, she can also take it. Otherwise, Sriram can also chip in. What would you classify as what's basic imaging that a private practitioner or anybody starting initially practice of retina need to have to confidently diagnose CSR? What is essential imaging and what is desirable imaging? So let's begin with that.
Anand, just a point. Supriya has not been
Yeah.
able to log in. I think we can rope
Okay.
in Manoj Khatri and Balaji Ramanathan instead.
Sure. You're welcome. Welcome,
Yeah.
Manoj and Balaji.
Manoj,
Okay, George, you can take it. Take it.
Anand, Balaji here. Just one point.
Yeah, Balaji.
Yeah, actually, there's now a very common concept that fluorescein angiography is dead and laser is also on its way out. So I'll tell you one thing, that in a disorder like CSR and with the rising stress level for all the people.
Balaji, we're not hearing you very well. Your audio is not very clear. Perhaps if you
Hello?
can just adjust.
Now?
Yeah, better.
Yeah, actually, what I was supposed to say is fluorescein angiography nowadays, actually, we're not getting newer cameras. And actually, the trend is to move towards OCTA. But this is one disorder where fluorescein angiography is something which is invaluable, especially for the treating thing. As ma'am was telling, she usually treats the FFA. And this is something which I think we should stress for the practitioner and the postgraduates. The fluorescein angiography is still relevant. And thermal laser is still relevant because there is a trend also to inject for CSR. I mean, without the CNM component. I just want to stress it. So it pays to learn fluorescein angiography even nowadays.
Very, very valid points, Balaji. George, your take on essential imaging and vis-a-vis desirable imaging.
Yeah, it depends on the presentation. As Dr. Kim and Dr. Sobha were already mentioning that the spectrum of disease that we are seeing has definitely changed. Not only the imaging, the presentation itself has changed. Over the last 20 years, what I have seen is we have seen more of fibrinous CSR, bullous CSR, multifocal CSR. I mean, when the first time I saw this, we actually mistook the fibrinous exudation, subretinal fibrinous exudation for a uveitis here. Actually, when encountered somewhere in 2005 or 6, we hadn't seen such presentations. Now, as not only the imaging, but the stress level of people, I feel, has gone up many folds. So that is why we are seeing all this. We have even published on choroidal detachments in CSR, in bullous variant of CSR in Retina Journal. So what I'm saying is we hadn't seen that even 5 years back. So coming to the imaging question which you asked, for a basic acute CSR, I still feel OCT should be the basic imaging modality we need to look, because as Dr. Sobha has already pointed out, it will give us a clue. And Dr. Sriram also said that even if the history is 1 month, it might show us the beautiful image Dr. Sobha showed, the photoreceptor elongation or hyperreflective foci, which are all pointing to chronic findings. So we get an idea what we are looking at. And especially, she also, Muna madam mentioned about the presence of subfoveal RP changes on OCT. So these are all pointing to whether to treat and to diagnose properly, and whether I would go with treatment not only based on 1 month history or 2 month history or 3 month history, but I would, these are the basic imaging. So now, where does the angiography come? So once angiography is not done usually to diagnose a typical CSR, it is only to treat the CSR. Once I decide to treat that patient, then we need angiography, as Balaji has pointed out, that we need an angiography. Unlike many of the diseases now, where we go for anti-VEGF therapy is the first line. We don't need angiography. I mean, most of the diseases, we don't need angiography as the first imaging modality. We can treat it based on OCT, even PCV, we can treat with anti-VEGF therapy and later go on. But here, once you decide to treat, first thing to do is angiography, because I need to know where the leak is. Is it a subfoveal leak where I go for a PDT? Is it a juxtafoveal more than 500 micron and persisting? I would go for a micropulse laser. And if it's a diffuse leak, probably I would go for a PDT, as the beautiful cases shown by Dr. Sobha. So this is how we image it actually.
Yeah.
Yeah. So yeah.
I
Sure.
just wanted to add to what George was saying about fluorescein angiography. The primary one is the OCT, and based on the changes that you see, I think even though you may not be treating, but I still might do a fluorescein angiography because of the different layer changes, the disruptions that you see in OCT.
Yes.
Is that
So
right?
fair to say that, for a CSR that comes in, I think OCT structural, when we say OCT, there are different modalities within our OCT machines itself. So structural OCT, let's put it out there, structural OCT, and given the, advanced imaging capabilities of OCT, current generation OCTs, structural OCT is critical. Alongside thrown in, it would be good to have fluorescein angiographic capabilities also, as George said, especially to distinguish when you decide to treat, also to differentiate from the different masqueraders that even acute CSRs can present, for example, choroiditis. Simple. So I think these two are critical. It would be also desirable and nice to have OCT angiography for reasons that Dr. Sobha has also mentioned. You would like to, in a non-invasive way, perhaps look at the networks below, to predict a neovascular network, and we'll come up with this situations a little later. And of course, indocyanine green angiography to look at the choroidal pathology and structure, as Dr. Sobha clearly said that, this greater, that everybody now calls it retinopathy. So, Dr. Sobha and Dr. Mona, when you're doing angiography, when you've decided to do angiography, will you always couple fluorescein angiography with ICG?
We don't, unless we also doubt whether there is polyp, because our decision to treat is based on focal leaks on fluorescein angiography. So we tend to restrict to that. But of course, it would be good if our photographers also did ICG. It's more a teaching rather, just to confirm our diagnosis, but we won't be using that to you for treatment.
Okay, so Vignesh, at Madurai, would you always do, when you're looking at CSR, when you think at CSR, would you always do a fluorescein with ICG? Personally, I can tell you, when I'm looking at CSCR, I know that, it could be part of that pachychoroid spectrum, as Dr. Sobha again talked of. So I need to know the choroid. So I always get a fluorescein with ICG. So Vignesh, what do you
no, I mean, the first investigation will be like only FFA. In the case of acute or chronic CSCR, and I add ICG only when I have a doubt, like when there is like when I doubt on a CNBM, which is not picked up on OCT angiography, or when I want to differentiate from PCV to identify polyps, and as well as like in case with PCRD. So many times in CSCR with posterior cystoid retinal degeneration, there can be underlying CNBM, which can be even missed with OCTA. So in those cases, whenever I have a doubt in chronic cases, to differentiate from PCV, as well as in case of PCRD, I add ICG, not routinely in every case. Because like in acute cases and as well as chronic cases with the simple leaks and FFA, it is easy to do micropulse laser for the leaks, which are identified at FFA. There is no need for doing ICG in every case.
So George, how do you go with it?
There's a slight difference.
I think you're muted. Yeah.
Can you
Go
hear
ahead.
me?
Yeah. Go ahead.
There's a slight difference in that actually. When ICG is reserved when you have chronic CSR, wherein especially when you see the diffuse RP, you expect. If I decide to do PDT, then definitely I would go for an ICG in combination with FFA, because the area which you treat. So focal leaks can be treated with focal, argon laser or even with a micropulse, but diffuse leak, if I expect a chronic case with diffuse leak, then I would go for FFA and ICG combined. And one more reason, this touched upon CNVM in CSR, that actually it's not, for me, it is not a great indication for ICG, because many a times, because of the diffuse chronic CSR, these CNVMs which are subtle could be missed or overlooked because of the background diffuse leakage that is already present in chronic CSR many a times. So in that, I would rather Octa is highly specific and sensitive in picking up these neovascularization under the what we call as fibed or flat irregular PEDs. So that is something which I beg to differ, but then this is my take on that.
Yeah. Also, I'd like to bring in also the role of autofluorescence, a very useful non-invasive imaging modality, which now I think most basic OCT machines are endowed with. So that's a great thing. And I think Dr. Sobha showed us beautiful cases of where autofluorescence gives us, very good clues as to the metabolic health, and may affect your treatment decisions also in terms of telling you how to prognosticate. So
I think
one thing, Dr. Yeah, go ahead.
Just a few comments on essential imaging. Sometimes when you see fibrin at the posterior pole, you look for a little bit of clearing, which can be seen clinically or even on a fundus photograph. And you also see that area of hypo on the OCT. So very often, if you run a video of your OCT, you will be able to pick up the area of leak because you see a small pigment epithelial bump and maybe a little strand of fibrin gets coming from it. You may even pick up a small pigment epithelial rip. So a careful look at the OCT will also help you if you don't have access to FFA. Then it will tell you, yes, is this a case where it's possible to do laser? Because if it's banged under the fovea, you can't, there's no point doing an FFA. So I would say a clinical photograph and a careful OCT is, with our new machines, is a fairly good first line of investigation for these already anxious patients.
Sure.
I think we call it the vacuole sign, isn't it?
Yeah,
yes. Correct. So I'll now just put out a few, we're kind of coming close to the limit. Some interesting and, challenging cases with CSR. So we kind of know how to treat the straight and easy ones. So how would the house treat a bullous CSR? Let's put that out first. So Dr. Muna, madam, and then perhaps George.
The first thing I would see look for in a bullous CSR is make the patient sit up and image them, because sometimes you can get an acute large giant rip of the pigment epithelium which causes an acute bullous CSR. And if that is there, then I'll just wait it out because the acute event will tide away and then you don't need to do anything, it settles down. It's the other type that is challenging when you can't see a leak properly. There is no rip of the RP, there's no break in the retina. And that's the one that you need to really look at, image better, and then see what you need to do about it.
Go ahead, George.
Yeah, in a bullous CSE with exudative retinal detachment, it's a really challenging scenario wherein the rip, I would definitely go for a combined FFA ICG in those patients. And if I see an extramacular rip, then we will not, as Muna madam mentioned, we will not go ahead with any, because it will subside. But then if it is a diffuse leak and multifocal leaks, then we have tried even eplerenone in such condition, but then it works in probably 1 in 10 or less than 20%. So that is a problem. So actually the best modality, if you find multiple diffuse leaks, is what we see usually in such cases. And especially you'll see fibrinous exudation and multiple pigment epithelial detachments. So this is what we usually see. In such situation, my treatment of choice would be going for a multi multifocal PDT, multi-spot PDT or multifocal PDT with half dose would be the ideal thing to do. I still remember, I think Kim sir also would remember, we had a bilateral, exudative retinal detachment known to him and a VIP patient, and who had this kind of a presentation with a lot of fibrinous exudation in a diabetic retinopathy kind of setup, and who had been tried everything, and finally he resolved only with this multi-spot, multifocal PDT in a sitting position. As very rightly said, to get a good quality in a retinal detachment, actually sitting position, get a wide field now with Heidelberg, and we at least get a wide field FA ICG combination and then treat with multifocal, multi-spot PDT.
Yes, I think that's absolutely apt, because I think this is one indication where wide field imaging for a disease which is largely posterior pole. This is one place where wide field imaging can help. And like both Dr. Muna and George said, that, if the patient is settling down, you have to wait, might settle down. And if it's largely because of rib, as it can happen very often, it's thick RPE, most likely to be the culprit. You can wait it out. But in the sitting position, if it's chronic and it continues to persist, and you find leaks which are where the which you have identified fairly clearly, you can perhaps accelerate that resolution with a bit of diffuse laser, be it PDT or even TGT. So the same Syed, what is if you're connected, what is your experience, or have you faced such challenges?
I think Muna ma'am.
Syed, are you there?
Syed, yes.
Okay, I think.
Anand, Syed is traveling, I think.
Okay. I just saw him connected, so fine.
No problem.
I would like to add one point on
Vignesh.
Sure. Yeah, so I have treated bullous CSCRs with epileronine as well as a combination with epileronine in micropulse. So in all the cases I have treated, it completely resolved. I mean, 100%. I'm not telling 10 or 20%. I have treated eight cases so far, and that is the largest series so far with epileronine in bullous CSCR. I had added laser in only 4 cases because to accelerate the reduction in fibrin. So actually, what I could see was when I gave epileronine in these cases, this fibrin got kind of melting. In few weeks, I could see even in 2 weeks, first case. So I was really amazed how it could melt so fast. And another case which was treated elsewhere as doubted as macular choroiditis and given oral steroids. And the patient was worsened because of the increase in the fibrin. And the patient himself stopped the oral steroid before coming to me. So once I saw that, actually that case went to UVA clinic, then they sent to me for FFA and ICG. I did FFA and ICG. I could see multiple leaks subfoveally, but there was dense fibrin. And then I treated with epileronine, only epileronine. In this case, I didn't even add micropulse because the leaks were exactly in the fovea. There was at presentation, the vision was 360. Right now it improved to 612. But the only problem was that subretinal fibrin, a small part of it got fibrosed and it is remaining subfoveally. So otherwise, in 100% of bullous CSCR, epileronine worked in my hands.
Okay,
Can
so
I ask?
Yes, Dr. Shobha, go ahead, please. Yeah.
All of you seem to be talking a lot about bullous. I've seen only 2 in my life in the UK. Is it more common than in the
ma'am. We see quite a bit actually.
Quite a bit. And
so
actually,
there is an ethnic difference then, because I clearly, it's a large hospital. I have seen only 2 cases so far. So
we definitely
there must be
do
something.
see.
There must be some clue to pathogenesis of CSR, right?
Possible.
One comment I'd like to make. There is a challenging situation now. We see CSR in pregnancy, and there are a lot of people who are put on steroids to maintain the pregnancy. So that is a particularly challenging situation where we have to counsel them to wait it out and just keep the obstetrician in the loop that yes, it is a steroid related problem.
So actually, that was the next one of the challenging situations I had kind of thought of putting out. We can take that straight away. So CSCR in pregnancy. So anybody with experiences?
Yeah.
So I can just tell you one particular thing straight away is that there was one of our staff who came in with the pregnancy, and we couldn't obviously fluorescein angiography. It rules out angiography earlier. So autofluorescence, this is where autofluorescence made a difference. And there was just one nidus of hyperautofluorescence, which corresponded to the PD, and therefore we just treated that, and that went off. So
Yeah,
please
Anand.
experiences.
So
Yeah,
you gave
Anand.
PDT, you gave Isudide in pregnancy?
No. Focal laser.
Focal laser. Okay.
Focal
Yeah.
laser. Focal laser.
Anand, to add to what you and Muna madam mentioned, these I have encountered few patients with pregnancy as well as steroids, and the unfortunate thing is those patients had fibrin also to complicate because of the steroid, and she had 5 more months to go to reach the term. So what I think Anand will definitely agree with, we have published also in those patients without angiography, we did a 40% subthreshold TTT large spot. The 3 millimeter spot, which is the largest, we empirically treated with, we try always a threshold, minimum threshold power extramacularly outside the arcade, and use 40% of that, which we have published as subthreshold TTT for chronic CSR. That's the only safe thing that we can do other than focal laser if it's a point leak, but then this works well actually.
I was planning to come to, treatments in the non-PDT era. So Vignesh, in his enthusiasm, sparked that up with eplenaron. So he kind of touched that. So I wanted to bring in, now, I mean, PDT is great. All of us, we absolutely concur that it's great. But in this non-PDT era that seems to be forced on us, and it's very painful, especially for treating CSCR. So in the anti-VEGF era with PDT, the surviving indications for PDT were CSCR, PCV, and say tumors, subtumors. But now that even PDT is taken away from us, I think the other treatment modalities which Dr. Sobha nicely showed, micropulse laser, eplenaron has a question mark. In Vignesh's hands it works, my hands it really didn't. And
even mine.
The study from UK, then it just showed that there's a question mark there. But perhaps there are certain indications for that, perhaps. But I'd like to bring in a discussion on micropulse lasers and experiences with this. So the PLACE trial which Dr. Sobha referred to compared PDT with 810 nanometers subthreshold diode. So personally, I've had a lot of success and positive experiences, and we have a group called the Subthreshold Ophthalmic Laser Society, which is published in the eye. Dr. Sobha was there. Our guidelines, our suggestions with Jay Chablani, Victor Chong, and a few others, and we believe this is of the indications for which subthreshold micropulse yellow laser can be used. Perhaps it's best for CSCR rather than even perhaps DME. So we've had positive experiences with micropulse laser, which even I think Vignesh would also concur. So I just like to first ask Dr. Sobha, in the UK,
I think
a lot of
Manoj has his hands up. Manoj,
Manoj. Yeah, I'll come to you, Manoj. Yeah, sure, Manoj. You have something?
Sir, you go on, sir. I will add on later on, sir. Please.
Sure. I just wanted to ask Dr. Sobha about experiences in the UK with micropulse yellow laser specifically.
Yeah, I have to be very honest with you. Like after the absence of PDT altogether, we actually are doing placebo treatment. We do nothing for our patients. Absolutely nothing. They were sitting here and looking. And if we attempt yellow laser, it will be like the ones that we would have attempted if it's acute CSR and rare indication. A lot of us, I mean, it would be good to look at what placebo does to our patients actually, because that we absolutely, I'm sorry to say, I'm very frustrated, but we don't do anything. So I have very little experience with 810. Of course, when I did it, it worked. But because of the PLACE trial, we are not doing that either. And it seems like, I don't know whether we are doing a good thing or not. I mean, fibrinous, pregnancy, everything, we sit and wait. We don't do anything. Of course, bullous, I don't see. I haven't seen much in bullous, actually. That was interesting. And none of us do anything much for the others. Yeah.
Anand, if I can add.
Yeah, George, yeah, sure.
Yeah, we actually, as you mentioned, we actually, because of the absence of limited availability of Visudine, we are doing but limited availability. And so we are actually doing, it took a while because there is no standard parameters for micropulse. So it took a while for us to come to the parameters that we are using now, because 5% duty cycle is really safe. So currently we are using for focal leaks, point leaks, which are juxtafoveal. That, I mean, really at the edge of FAZ or within 500 microns of the FAZ, we are using only for point leaks at and around the FAZ area, 500 microns. So that it works, but then it doesn't prevent recurrences. As you rightly mentioned in your talk, it doesn't prevent recurrences, but at least we have something to offer to the patients who are really symptomatic.
So just to, clarify there, our, what we put out from the Salt Society is, 5% duty cycle is what we have consensus for, 200 milliseconds duration, 100 to 200 micron spots. And of course, if there are definitive focal leaks, then it's a no-brainer. We go ahead with that. But if there are diffuse leaks, and that is where the real challenge is, diffuse leaks, and especially if it's around the posterior pole, we have no qualms in treating the entire posterior pole macula, and it's been shown repeatedly with autofluorescence as well as, structural OCT to be fairly safe, and this can be repeated again in 3 to 6 months. So I just want to, put that option out, because we live in difficult times without PDT. So that is there. And yeah, Manoj, we'll have your comment, please.
Yes, thank you so much, sir. The only thing with micropulse laser in our short experience of about 13 odd cases is the predictability is very, no, we are not very sure like how much of laser, and we are not able to see the laser burns also sometimes because of the diffuse fluid there or the fibrin sometimes. And the second point is the repeatability rates are very high. So convincing patients even for lasers again and again become very difficult. So this thing, we have to keep it in back of our mind whenever we are doing micropulse laser for these patients.
Okay. So yeah, sure. Yeah, Vignesh.
We have tried even in subfoveal leaks, we have done micropulse like very safely.
Exactly.
Threshold, like juxtafoveal, subfoveal leaks in the papillomacular bundle. Whenever the leaks are like seen like focal leaks, we are seen like it is very easy like to do micropulse, and we can also repeat it very safely. So we can go very safe. Do it safely. So only question is like, since we don't know the endpoint, like when we are not seeing any visible laser there because we are using threshold. The only thing is whether we are under treating or not. That is the only question we having.
Precisely. That is why the Salt Society has, put out these guidelines in the editorial, in a comment from I. So we'd encourage people, to try to use this modality. I think it's a useful modality. It has also applications in DME. Of course, it's beyond the scope of this webinar. But I think that's what it is. So I see that we are almost close on time. We seem to have discussed a wide range of topics ranging from imaging to treatment modalities and challenging situations. So with that, I'd like to hand over my mic to Dr. Kim for his last few words.
Thank you, Anand. Thank you, Dr. Sobha, I think, and the entire panel for such a, I know there are still a lot of questions that can go on and on for this topic on CSR. I think we can have one more symposium on that, because there are that many unanswered questions in this. Yeah. So I think you did a wonderful job, and thanks, Anand, for bringing out all those important points, and the panelists for sharing their experiences. Thank you, RK sir, for this opportunity. Over to you, sir.
Thank you, Dr. Sobha.
Thank you, Dr. Sobha. Really, it's an eye-opener for all of us. I didn't know that so much in CSR. It's very nice. Completely total change in the mode of approach, the diagnostics and treatment, what we were seeing about 3-4 decades ago. Now it's really is different. Thank you so much. And also thanks Kim and Anand for wonderful thing, and also all the panelists. I am really happy that it's really a wonderful discussion. Now I request my dear Sriram Gopal to propose what's up there. The Secretary of
Thank you, sir. My heartfelt thanks to Dr. Sobha Sivaprasad, who took time out to address us and share all her wonderful pictures, amazing pictures, ma'am. I've been getting messages on my phone about how wonderful your pictures are. So thank you so much for it. Thank you for such an eloquent talk. Thank my dear teacher and the convener of this session, Dr. Kim, and my good friend, Dr. Anand Rajendran, who so casually and so smoothly conducted the whole session and took everybody in and brought out the best points from everybody's minds. And my co-panelists, my teacher, Dr. Muna Bende, my friends, Dr. Vignesh, Dr. George, Dr. Syed, Dr. Manoj Khatri and Dr. Balaji, the other office bearers, and my sincere thanks to our dear president, who's made it a point to have one international invited speaker every month from August of 2022, at least one. There have been a couple of months where he's had more than one, but at least one international speaker every month on a webinar. And sir, I'm feeling very sad. You only have 2 more months of presidency left. I think we'll file for an extension. So thank you, sir. Thank you so much. And thanks to our technical support, Numerotech, and our sponsors, Orolab, and to all the delegates who took time to log in and see it. Of course, this video, as usual, will be available on the TNA website forever. So even people who missed out can always go back later. And if you feel you missed some point or something, even we can actually go back and look at it. Thank you so much. And I take this opportunity to invite everybody who is watching this now to the annual conference of TNOA in the first week of August, TriCon 23. Welcome everybody, and thank you once more.
Thank you all.
Thank you, Shriram. Thank you, RK sir.
Thank you.
Thank you, Dr. Shobha.
Many thanks, everyone.